Hey guys, Bret Contreras here. Today's topic is on back pain, and this is something that I think deserves more attention from strength coaches. I've heard a lot of physical therapists talk about it, but I don't think I've heard any strength coaches really do it justice. So I hope you pay close attention because, again, this is a topic that will improve your ability to help your clients. So specifically, I want to talk about two different models with back pain. The first is the Psp model, and Psp stands for Postural Structural Biomechanical Model. And the second model is the BPS model, or the Biopsychosocial Model. So I'm going to start off with the Psp model. So the Postural Structural Biomechanical Model, it dictates that the things that cause pain would be related to the things that cause back pain would be related to posture, structure, and biomechanics. So I will explain this. You could under this model you could analyze somebody's anatomy, for example. You could look at their posture and positions. You could look at their form and how they move, and then you could determine by this, why they are stressing a certain part, part of the body, a certain part of the spine too much, and that's why you are causing mechanical low back pain. I will say that based on what I've seen, I feel that physical therapists need to give this model more concern. A lot of the physical therapists in the last couple of years have completely drifted away from this model to the biopsychosocial model, saying that chronic back pain, saying that back pain has nothing to do with posture, biomechanics, or structure. It only has to do with the nervous system and the biopsychosocial model. And if that's the way you think, then you're missing the boat, because the Psp model came first, and it's there for good reason. If you're a strength coach, if you're a personal trainer, you've seen this happen over and over. If you don't believe it, just stand up and arch the hell out of your lower back for 5 minutes. Do it with heavy weight. Do it over and over for one day. Do 20 sets of back extensions or deadlifts while hyperextending, or round your back. Do a bunch of round back deadlifts with heavy weight and see how you feel the next day. And then tell me that that biomechanics has nothing to do with low back pain. Anyone who says that is absurd. They're just they don't get it. They don't understand what they're talking about. So I'm going to talk about this model for a few minutes and then drift over to the other model. So this model applies better to athletes and to weightlifters, and it applies more to acute pain. It does not apply as much to chronic pain. So that's very important to understand here. Chronic pain is more related to the biopsychosocial model, and acute pain, I'm lifting weights and I feel a sharp pain in my back. Something went wrong. Well, that's probably due to biomechanics and posture and structure. And again, obviously, athletes and people exercising and people lifting heavy weights, when you're holding on to a weight or putting a weight on your back, you are now, and you're lifting weights through a full range of motion, like squatting and deadlifting, you need this core stability. If your spine wiggles around under heavy load, you're going to increase the chance of injury, of pain and injury. So I will break down the three mechanisms in this model: posture, structure, and biomechanics. So the first is structure and anatomy, and this looks at your skeletal structure, the size of the size and shape of your bones, your anthropometry, your discs, your vertebrae, your sacral slope, your pelvis, and all these different measures of anatomy. And studies have shown that that your chance of getting an injury, a low back injury, is related to posture. If you have certain, like an anterior, like a very steep sacral slope, you're going to have more shear force on that L5S1. But I will tell you, a lot of studies show that like pelvic tilt and different mechanical factors are not related to chronic pain. Well, I will tell you, in the weight room, this does matter. People who have anterior pelvic tilt or lumbar hyperlordosis, they do have much higher incidences of feeling their low back hurt with certain exercises. And conversely, people who have posterior pelvic tilt and lumbar hypolordosis have increased risk of experiencing pain and injury in certain exercises. I'll deal with that in a second. But posture relates to the different positions. Your posture when you squat. Are you how arched are you? Do you round over? Posture is what kind of positions do you sleep in? Uh, do you sit all day long? The positions you get yourself in throughout the day. Structure is anatomy, but it's not just the skeletal structure. It's also the muscles and where they insert, the origins and insertions, and strength balances, things like that. And your biomechanics would also be influenced by your strength balances. So you want, in general, you want the muscles on the front side of the body to be as strong as the muscles on the back side of the body. You want balance in there. Depending on the exercise, some muscles get activated higher than the others, but you want a balance. For example, if your lumbar, if your erectors are very strong and your hip extensors are not very strong, then your chances are you're going to want to pick things off the floor, deadlift, or do good mornings, or even squats. You're going to want to use your back more. You're going to want to use those muscles dynamically. So this all influences your likelihood of experiencing pain. For example, if you I'll talk about the knee for a second. If you are squatting, and your knees cave in as you come up, your knees cave in while you're squatting, this will put more pressure on the lateral sides of the knee, and you have a greater chance of experiencing patellofemoral pain. So in that sense, biomechanics influences the likelihood of pain and injury. With the lumbar spine, let's say you are hypolordotic, you have an excessive curvature of the lumbar spine, it's arched too much, you have anterior pelvic tilt, excessive anterior pelvic tilt, and you are doing a back extension or a hip thrust. And as you come up in the hip thrust, or as you hold the weight and rise up in a back extension, if your anatomy is already, those posterior elements of the spine are already closer together. They're already kind of jammed closer together. And so now, if you are the type who uses moves into even greater hyperextension, or you relies too much on your erectors, say you don't have strong glutes, you don't know how to control pelvic tilt, and you want to rely on your hamstrings more, you will tilt the pelvis more forward into anterior tilt, and you will arch the back even harder as you come up, and you will jam those facets together, the facet joints, and you have a higher likelihood of experiencing pain and injury. So in that sense, anatomy, posture, and biomechanics definitely plays a role in injury. And on the flip side, let's say you were in posterior pelvic tilt, you have a flattened lumbar spine, it's hypolordotic, and you kind of have no glutes, you don't know how to activate them well. And these types of people typically will round over. They want to round with everything and just use their spine dynamically to lift things up. So you give them a deadlift, and they will round over and pick the weight up. They are using their hip extensors statically and their erectors dynamically. And they will have increased chance of herniating a disc and getting back pain from deadlifts because they will want to round. So, as you can see, there are a lot of examples. Another one is sleeping. You sleep in an awkward position, it's going to hurt the next day. Again, like I said earlier, do a heavy round back deadlift and, let your form slip too much without controlling that lumbar spine, you are going to feel it. In lifting, there's often a biomechanical explanation for this pain. And so usually people's backs hurt due to excessive motion during lifting. And so we talk about core stability. This does not mean that the spine doesn't move. It just means that we prevent excessive motion, and too much motion and not enough, strength at the hips and things like that, and you increase your chances of injury. So that's the postural structural biomechanical model. It is very plausible with weightlifting and sports. And typically what we do is we, go through the process of teaching somebody how to be a good lifter. We will give them, for example, hip mobility drills to increase their hip mobility. We'll give them core stability drills to increase their core stability, glute activation drills to get their glutes activating better, and motor control exercise will really stress good form with light loads. So we might give them, psoas stretches, rectus femoris stretches, hip internal rotation stretches, walking knee hugs, different types of lunges, planks, side planks, Pallof presses, glute bridges, sideline clams, sideline abductions, hip hinging drills, box squats with lightweight goblet squats, things like this, and get them using very good form, get their knees tracking over their toes, get them hinging at the hips, keeping the core stable, get them feeling the glutes working, and voila, this works miracles for a lot of people. People who always said, oh, I can't do squats, I can't do deadlifts, I can't do this exercise because it hurts my back. All of a sudden, they are, performing these movements pain-free, and, they love you to death as their coach because you just, taught them how to lift without hurting their back. So that is the postural structural biomechanical model, and it is very important for people who work with people in back pain, be it manual therapists or physical therapists or strength coaches, personal trainers, athletic trainers, doctors. They need to understand this model because it's very, very important. It's a very important model for a good reason. However, if this is all you are only aware of the postural structural biomechanical model, and then all you have is a hammer, everything looks like a nail. So I will tell you in my own personal experience as a personal trainer, this is all I used to know about. And so everyone who came to me and said, Bret, my knee hurts or my back hurts, I just thought, oh, it's because they have crappy form, and they're weak in certain areas or tight in other areas, and they need to receive specific corrective exercise, stretches and strengthening exercises, and then it'll fix their form up and their pain will go away. Well, and sometimes I was probably fooled because pain tends to go away anyway on its own. So I probably thought, oh, I fixed them. And this does not work with everyone. First of all, it doesn't work with people in chronic pain. It actually can work, and it can be very effective, but for reasons other than what you're thinking. I'll get to that in a minute. But it also doesn't work for people who need surgical interventions, who have serious issues wrong with them. It's not always strength related or flexibility related or motor control related. Sometimes there's an issue that requires, a surgical intervention or a different approach, and the solution is not just exercising. I will say that studies show that bed rest is not good for back pain. You don't just want to lay around all day long. You do want to be moving. Movement is often the solution, but not always for the reasons why people think. So this leads me to the next model, the biopsychosocial model. Now this model is very important to understand. Strength coaches need to give this model more concern. They need to understand this. And this applies more to people in chronic pain, more to sedentary folks who aren't exercising all the time. And chronic pain that's been there for a while, it's not just due to biomechanics. It's more due to things like biology, psychology, and sociology. Hence the biopsychosocial model. So let me explain this. If you were to take 100 people, and some of the people are in pain, some of the people are not in pain. You were to take MRIs of all those people, and you were to look at different joints. You were to look at the knee joint, the lumbar discs, and different joints, shoulder joint. You would see evidence of degeneration in almost everyone. In fact, studies show that there's evidence of disc degeneration at age 2. It's just a natural consequence of living. We degenerate over time. And so a lot of these, very eye-opening, studies have been performed where they look at these MRIs of a large number of people, and they can see that it's not, pain and injury is not, pain is not highly related to biomechanics and anatomy and things like that, or to damage, to degeneration. You will see a lot of people who have, a degenerate disc, two degenerative discs, and they exhibit no pain whatsoever. They're asymptomatic. And conversely, you can have somebody who's in severe pain who doesn't, you look at their MRI and there's no explanation why they should have pain because it looks normal. And so, things like posture and biomechanics and structure are not highly correlated with chronic pain. Most of us are jacked up at most of our joints. I mean, you sitting there listening to me right now ramble, you probably have degeneration throughout your body, and you probably don't feel it, and there's a reason why. So if you just think of pain as like, oh, I punch my knee, ow, it hurts. That's not, this pain signal, it will travel from your knee up to your brain, but your brain has to make a decision as to whether to send a signal back down to that spot and elicit a pain response. So the brain in chronic pain, they're always sending that pain signal. It doesn't shut down. And chronic pain has been shown to be correlated with things like depression, number of friends and support group and confidence and things like that. So how do you deal with the chronic pain person? Well, the first step, in my opinion, is teaching them. Knowledge is the first step. They need to be aware that they are not destined to have back pain for life. They can overcome it. And it starts off with knowing and believing that you can overcome it. First of all, damage can heal. Herniations are in a state of flux. They can heal. They don't. You get biomechanically inferior healing, but they're in a state of flux. They will improve a little bit. And biomechanics can improve too, so your form and things like that through strengthening. But it's not necessarily, let's say you have somebody lifting weights and getting stronger, it's not necessarily that they're improving their biomechanics or their form. Or let's say you're using manual therapy, massage and techniques and things like that. All these different, there's a ton of different techniques that have become popular over the last, decade. They don't always work for the reasons expected. ART was the first thing that really got popular, since I've been around in the strength and conditioning industry. And ART proposed that you are, you're targeting trigger points and getting the trigger points to settle down. You are breaking up adhesions and scar tissue. This is not all, sometimes you can do ART on someone and it might relieve their pain, but it's not because of those reasons. A lot of people have really glamorized fascia in the last decade, and they feel that fascia has these magical properties, and that's the secret to healing chronic pain. And it's probably not related to the fascia either. It's probably not related to any tissue other than the tissue related to the nervous system, the nerves in the brain. And the pain is a nerve and brain phenomenon. And so when you heal people's chronic pain, when you get them out of chronic pain, you are essentially teaching their brain to not elicit that pain response. And so all these things that people do that have been successful can work. Movement, manual therapy, things like that, ART, but it's because of different reasons. You are altering the brain's perceptions and the nervous system's response. And so when you do, let's say I get a client and, they tell me that they can't do certain exercises because they have back pain and it hurts. Well, what I will do, hopefully they've been to physical therapists and things like that. I don't just take on any client, but what I would do is just try to see what can I give them that's pain-free. Can I give them a really high box squat? Can I give them a hip hinging movement with short range of motion? Can I give them glute bridges? Maybe feet elevated glute bridges. Maybe I have to use bands and cables to assist them, so they're only lifting a percentage of their body weight, but I get them to do things that they can do. And this also applies to the manual therapist and people who are doing things. And what this does is it increases their confidence. It decreases the threat, the fear. A lot of this pain is due to fear and this threat of movement, and you're essentially teaching their body it's okay to go through this range of motion. And little by little you chip away at this, and they increase their range of motion, and they increase their strength and their loading. And all the while, they've got a good personal trainer or massage therapist or strength coach who cares about them. They feel that love there. They know that they've got a trainer who cares about them. They are confident in their trainer. They believe in the trainer. The trainer praises them, pats them on the back, and little by little this helps because it increases their confidence. It decreases that threat response, that fear, and little by little they learn to override their that signal, and now the brain doesn't keep sending that signal down to elicit chronic pain. And so again, movement might be a solution for either model, but you need to be aware of this because they need to understand that it takes time. If it took you a lot of years to get into this pain, and the pain could have started from a biomechanical reason, maybe you herniated a disc doing deadlifts and then just never rehabilitated, never got over it, and your brain just learned to be very afraid of this and to keep that signal kept persisting. And I think this explains why all serious lifters hurt themselves several times throughout the year, and we can get pretty bad injuries, and then we're up lifting, training around it a few days later, and if you've been through this before, you kind of know I just need to be smart and not be stupid, and I will be okay. And there have been many lifters who have come back from debilitating injuries to set new levels of strength records and things like that. So I hope you've enjoyed this video. Again, it's important to understand both models. If you want to look more into it, you could type into Google, the Biopsychosocial Model and the Postural Structural Biomechanical Model, and you will get links that you can read. There was a man named Anup Balandrakhan who wrote an excellent blog post for me, a guest blog post on my blog a couple years back pertaining to pain and chronic pain. There is a website, somasimple.com, SOMASIMPLE.com, where they teach people a lot about pain and how it's related to the nervous system. And Stu McGill, a professor in Canada, a spinal biomechanist, has published lots of papers on biomechanics of low back pain and things like that. He's written 2 books as well. So these are all resources you could check out if you're interested in this topic. But again, therapists, coaches, personal trainers, athletic trainers, doctors who work with this type of people need to understand both models and how they jive together. So again, hope you like the video. Thanks for watching.